Hello, everyone. Thanks, Haley. We are going to get started. Thank you for joining our event tonight on the impacts of climate change on clinical practice. We're so excited to have folks from all over the world. I know that we're logging in from many different time zones, so thank you for taking time out of your morning or evening to be with us. My name is Natasha Sood. I am a rising fourth-year medical student and the current student fellow at the Global Consortium for Climate and Health Education. I will be moderating the event for tonight. As I mentioned before, if you would like, please introduce yourself in the chat, mention where you're located so we can see where everyone is logging in from. Also, throughout the session, please make sure that your mic is muted so that we can hear from our expert panelists. And also, please drop any questions you have in the chat. I will be compiling everything and make sure that we address them as we move forward. So today we will be using a mini case to learn how climate change is affecting health management. We know that climate change is impacting health directly and indirectly in many ways. But we also know that when we work together across specialties, as we do in healthcare, we can deliver excellent care even in the face of the climate crisis. So today we hope that this interprofessional panel will give you an idea of these wide-ranging impacts and the way that our health teams can come together to address these adverse health outcomes. Today we will be hearing from specialists in emergency medicine, physical medicine and rehabilitation, advanced nursing practice, and pharmacy. And without further ado, I will introduce our experts. Can you see my screen, Haley?
Yes.
Perfect. All right, so today we will be hearing from Dr. Colleen O'Connell. She is from Physical Medicine and Rehabilitation. She's the medical director and research chief at New Brunswick's Stan Cassidy Center for Rehabilitation and is the clinical research director for the University of New Brunswick's Institute of Biomedical Engineering with faculty appointments at the Dalhousie University Faculty of Medicine. She's also the past president of the Canadian Association of Physical Medicine and Rehabilitation. Dr. Emily Spirioli is coming from emergency medicine. She recently completed her residency at UC San Diego, including 1 year as chief resident. In 2019, she was named the Emerging Physician Leader by Healthcare Without Harm's Physician Network, and she is the National Physician Fellow, currently working with the US EPA and Healthcare Without Harm. Dr. Teddy Potter from Advanced Nursing Practice is a clinical professor at the School of Nursing at the University of Minnesota. She's a specialty coordinator of the Doctor of Nursing Practice in Health Innovation and Leadership, and she's the director of the Planetary Health for School of Nursing. She co-founded the Health Professions for a Healthy Climate, and she's a member of the coordinating committee here at GCCHE, as well as a member on the steering committee at the Planetary Health Alliance at Harvard. From pharmacy, we have Dr. Alice Gabauer. She's an assistant professor of pharmacy at the University of Charleston in West Virginia and a board certified ambulatory care pharmacist. She is leading the introduction of sustainability topics in pharmacy curriculum and is the co-founder of RX for Climate.org. So welcome to all of our panelists. Thank you for being here. We're really excited to have you here. And also, we will be recording tonight's session and we will be uploading a recording of this event, the case materials and the bios of all of our speakers so that you can learn more about where they are coming from. All right, so for today, can someone confirm that you can see the presenter mode on my screen?
The panelists are showing.
Yes, thank you. All right, so for tonight's session, we would like to use this hour to highlight each field's responsibility in providing care for the patient case that we will explore, especially as it relates to the patient's climate risks. And number two, we would like to demonstrate best practices for communicating risk management and assessment to both colleagues and as well as patients and their families. So now we will hear briefly from our panelists. After that, we will explore the mini case that we have developed. And then finally, we will open it up for discussion As I mentioned, please feel free to drop your questions in the chat, and we'll make sure that we address them as we move along. To start off, we will briefly hear from our panelists, what is your role on the healthcare team and how has climate impacted your profession? You're more than welcome to use an example to illustrate this. And to start with, we will start off with Dr. Emily Spirioli. Thank you.
Thank you so much for the introduction, and thank you all for having me. And I'm looking forward to this discussion. I think it'll be really interesting for everyone. So for myself as an emergency medicine physician, you can imagine that we are sort of on the front line of this problem. Whenever there's a climate emergency, some sort of extreme weather event, a mass casualty incident, anything like this, the emergency department is typically on the front line of that issue. We're also often the safety net of our communities. So whenever there's a disruption in access to healthcare, so for instance, patients can't get to their primary care providers for whatever reason, they come to us. So we are definitely very aware of this, at least in my specialty. There's a lot of leaders in my specialty that are kind of pioneering the clinical movement for the healthcare sector to become leaders in solving this climate crisis problem. And so for our role, I mean, we basically serve as whatever the community needs, and then also communicating to policymakers and to the public on what we're actually seeing, how it's impacting our patients, and advocating for climate mitigation as much as we can.
Thank you, Dr. Spirioli. And next from Dr. Aliska Bauer.
Hi. Also, I want to also thank you for having me here. I'm really excited to be on this panel and learn from the other panelists. So for pharmacists, I think our main focus is always helping people obtain medications, helping people take and store their medications properly, and helping people avoid adverse effects from their medications. So of course, we're always routinely focused on those, but in the event of disasters, all of those things become much harder. So for example, in terms of obtaining medications, in a disaster, a patient might not be able to get to their pharmacy, and or the pharmacy may be shut down. And that actually happened in West Virginia here a few years ago when we had some severe flooding in 2016. All the pharmacies in that area were inaccessible from the floods. And so the patients had to rely on an emergency clinic that got set up nearby to provide their medications. And then that wasn't the end of the problem, because then when there was a supply, the next problem that arose was knowing which medications everyone was supposed to take. So I'm sure everyone is familiar with, a lot of people are on more than 10 medications each. A lot of people rely on their pharmacy refills or their pill bottles, pill boxes, or their caretakers to help them know what they're supposed to take. And then disasters can really disrupt that whole system and leave everyone quite confused. Storage of medications is also a pharmacy concern that can be a real problem during disasters. And some medications, so insulin in particular, are quite temperature sensitive and can become ineffective or unsafe when they're not protected from extreme hot or cold. Or drugs that get exposed to unsafe water are also unusable. So storage is another disaster issue. And finally, pharmacists are concerned with adverse effects of drugs. And sometimes that can be really relevant to weather, especially hot weather, because as patients become dehydrated, their blood levels may go up. And also because some drugs interfere with the body's ability to regulate its own temperature. So psychiatric drugs are particularly notorious for that and have even been linked to excess mortality during heat waves. So I think those are the main focus areas in terms of pharmacies for disasters: obtaining, taking, and storing, and avoiding adverse effects.
Thank you so much. And then from Dr. Potter. Dr. Potter, I think you might be muted.
I'm going to be sharing my screen so that you can see what nurses do. It's hard to understand what we do unless you understand who we are. So I'm going to briefly walk you through how nurses think, and just how we think in comparison to our wonderful colleagues who are physicians. Physicians start with history and physical, which the case that you gave was a classic physician history and physical. You're gathering as much data as possible, and then you're running exams and labs and scans to determine of all the variables, sort of you're doing a process of elimination to figure out what you're really dealing with. And the goal is to get down to a differential diagnosis, either one, too many, but it's that differential diagnosis that's treatable. So it's a process of getting down to what you're looking at and being able to determine what you can treat. Nurses, however, we begin with the patient and we ask more and more questions, because this is where care occurs. And so we're always adding more valuables and that are related to health and the impacts of health in their families. In that respect, both of our professions together really make up a perfect whole, in that we are complementary to each other. So in an emergency, in a dire emergency, nurses, our primary focus is always safety and advocacy for patients and families. That's our first thing that we're looking for. But after that, after the person is stabilized, we're really doing some deeper assessments, and you can hear the difference compared to the case study of what we're looking for. What I didn't see in the case study was the primary care provider. That's really essential to know who's a part of this person's team, advanced directives, their code status, and certainly their diet. You might think, well, it's an emergency situation, I don't need to know their diet. But if they can't swallow, absolutely, you need to know if they're on thickened liquids, or they get their food and their nutrition through a G tube. That's something that we need to know. You need to know their primary language, their education, their literacy level, their diabetic knowledge, as this case reveals, their hypertension knowledge, their hyperlipidemia knowledge, their medication adherence. What's their housing like? We know that this person lives in a high rise. But is it adequate housing? Is it safe housing? Are there vermin, are there pests in the situation that make it unsafe? Do they have adequate electricity and water and heat as necessary? Does this person use a wheelchair? We know they have an amputation. Do they need assistive devices? Do they have a prosthetic? How well does the prosthetic fit? And what's the function of their prosthetic? What's their spiritual tradition? Social relationships with people that live close by. Then we know they have family that live across the country, but do they have relationships close by that they can rely on support? What's their occupation? What are we going to be rehabilitating them to? Do they need have a current work, or are they out of work? Are they on Social Security income or disability? What are their hobbies and interests? What are the types of things that they want to be returned to? Do they have a history of trauma? Have they experienced racial disparities and racial inequities? Are they a veteran, and do they have military status? Are they using chemicals beyond smoking? That was in the case study, but are there other chemicals that they use? All of these things are what nurses would need to know. And why? Because our role is to teach people about their chronic illnesses, to evaluate their diet and activity and their medication use, to address social determinants that impact their health, to equip them with knowledge, and then related to climate change, to prepare them for disasters. Do they have access to cooling centers? Do they have an escape route planned? Do they have a bag or some quick, ready sort of a way that they can grab their medications and important health information? How are they going to care for and manage for their pets? We teach them resiliency about climate change. So preparing them for bad air quality days, high heat days, days where dehydration are going to be at an added risk for them. And how are they going to protect themselves in severe weather? This is a particular concern when people have disabilities or limitations. We need to ensure their safety. And we, to mitigate the climate change issue, we're encouraging all patients to, as much as possible, follow a plant-based diet. So that's a snapshot of who we are and how nurses would approach this.
Thank you so much, Dr. Potter, for that thorough introduction. And next we have Dr. O'Connell.
Hi, thanks very much. And I just wanted to mention that I'm replacing one of my colleagues, Dr. Marka Lee Alexander, who has intended to be here with you. She's one of the most passionate physical medicine and rehab specialists I know, who's been at the forefront of promoting the implications of climate change and its impact on persons with disability. So unfortunately, she had a death in the family, and they asked last night if I could take her place for today. As a physical medicine and rehabilitation specialist, we work with people who have disability, whether that be cognitive or physical. And persons with disability tend to be among the most marginalized and vulnerable populations, particularly when you include issues on top of that of gender and of other racially potentially marginalized persons. In any sudden onset disaster or a climate related event, persons with disabilities are particularly vulnerable. And they're vulnerable not just to increased intensity of experience of the disaster, but also a disaster can predispose persons to becoming disabled themselves. And so part of our role as physical medicine specialists, and I know Teddy, that was a fantastic introduction on a holistic approach to the management of an individual. And we take that type of holistic approach in physical medicine and rehabilitation. We're a little different than most medical specialists, where we're not predominantly coming at only a history and physical and a diagnostic perspective, but how do we assist an individual in achieving their maximum and optimum level of functioning and quality of life while minimizing the burdens and risk. And that fits nicely with disaster preparedness, where we look generally at 4 stages of disaster: mitigation, preparedness, the response, and recovery. And so we see ourselves as physiatrists having an integral role in helping our patients both in preparing for the potential of disasters and climate change. And then in an actual response, how do we advocate and ensure that persons with disability and their issues are taken into account in regional and national disaster preparedness activities? We saw very intensely the negative impacts of not having those considerations in the aftermath of the floodings in Hurricane Katrina. And persons with disability who are reliant on wheeled mobility were not accommodated for in evacuation processes. Many of them drowned in their own homes while awaiting for assistance. I personally have worked in areas following sudden onset disasters and earthquakes in Haiti and in Nepal, and I can very much support the important issues of having access to durable medical equipment such as wheelchairs, mobility aids, access to their medications. We saw a significant increase in AIDS and HIV when the clinics that provided the AIDS treatment drugs, HIV treatment drugs, were no longer accessible. And we saw a dramatic increase in that even just following an earthquake. So those long-term implications. So as a physiatrist, we're really there to try and prepare and mitigate and then be available in the response, thinking of that holistic approach to our persons with disability that put them at particularly vulnerable situations.
Thank you, Dr. O'Connell, and the rest of our panelists for those very thorough introductions to your role on the team. We will now get started with our case. I am dropping a link in the chat. This is all of our case materials so that you can follow along as we move forward. I will also be sharing my screen to work through the case. All right, so our location for this case is the Pacific Northwest in July 2021. Our history of present illness is a 60-year-old patient with a history of hypertension, diabetes, hyperlipidemia, tobacco abuse, status supposed left below the knee amputation in 2019. Presenting to the ED with concern for confusion, profuse sweating, altered mental status. He arrives via EMS, who report that he was found on the steps outside of his apartment by neighbors who called 911. Per the report, he lives alone on a top-story apartment. He has a daughter who lives in New York, per the report from neighbors. And his field vitals are heart rate 138, blood pressure 90/50, respiratory rate 32, blood glucose 423. The patient is unable to provide further history as he's 2 out of 2 AMS, altered mental status. He's on several medications, including lisinopril, hydrochlorothiazide, metformin, Lantus, metoprolol, gabapentin, and Seroquel. His hospitalizations include a tonsillectomy at age 7, an appendectomy at age 16, and a below-the-knee amputation on the left side at age 57 in 2019. He is allergic to penicillin, and he develops a rash if exposed. On physical exam, he is an obese male, generally ill-appearing and moaning incomprehensibly. He has dry mucous membranes. His pupils are equal, round, and reactive to light. His neck is supple, and his trachea is midline. His head is normocephalic and atraumatic. He is tachycardic with an irregular rhythm with 1+ pitting edema bilaterally. His distal pulses diminished throughout. On respiratory exam, his breathing is spontaneous and he is tachypnic with clear lungs. He has a soft abdomen, which is mildly distended with hypoactive bowel sounds. On extremity evaluation, he has a left below the knee amputation with a well-healed surgical scar, and he is moving all extremities. No other deformities noted. On neuro exam, he is moaning incomprehensibly, and his cranial nerves are grossly intact, but he's unable to follow commands. All right, and so as I mentioned, please follow along on the document I pasted in the chat. But for now, we will hear from our panelists again. For this question, we first ask to please identify the pertinent climate risk for your respective health specialty and other health risks, and how you would communicate those risks to other providers and colleagues. And we will start with Dr. Teddy Potter.
Thank you. Is this the question? I'm not quite sure. Are you talking about in general or related to this case?
Both. Any health risks and climate risks that you would like to talk about from the case itself.
Okay. Climate risks are certainly individualized based on the region somebody lives. And so in one group, you might be preparing them for hurricane risks, another profound droughts, another here in Minnesota, polar vortexes in the winter, where people who are outside do outside labor are at high risk for frost burns and frostbites and things like that. So it depends on the individual, it depends on the work, it depends on where they live. And when I'm speaking with my colleagues, basically now there's enough evidence out there, scientific evidence, that I'm not trying to convince my colleagues that climate change is real. It's more, what are we going to do about it? Some still believe that it's not related to their health profession. So that's where usually my conversation goes, is why is it a absolute imperative for health professionals to be involved in protecting our patients and making sure that they can be resilient in the midst of very challenging environmental situations.
Thank you, Dr. Potter. And next from Dr. Emily Spirioli.
Sure. So this patient is classic for the emergency department in these kinds of situations. One of my first cases that I ever had as a resident that was a climate-related case was something almost exactly like this, except it was a 93-year-old female who also had a mobility problem, and she was stuck outside in the heat wave because her mobility wheelchair had lost its battery. So I'm very familiar with this kind of presentation. And what I would like to draw attention to is a few things. So first, this is an all hands on deck patient. This patient is going to come into the emergency room, and the ER team, we're already going to know about him because our EMS colleagues in the field are going to give us a heads up. So they're going to call us in advance and tell us, hey, look, in 5 minutes, we're coming in. We have this very sick patient. He's hypotensive, he's tachycardic, he's tachypnic, he's extremely sick. So this is all hands on deck. We're going to get everybody involved in the emergency department. We're going to get all of any doctor that's available right away. We're going to get all of the nurses to get everything ready for the patient's arrival. We're going to let our pharmacists know that we're getting a sick patient. We're going to let our technicians know as well. Everyone's going to be ready for the arrival of somebody like this. So you can imagine from a healthcare perspective, if this is just one patient who's having this kind of problem in this heat wave, there's probably more. So from a hospital-wide perspective, we need to be ready for these kinds of field disasters. So for him specifically, you mentioned his medical history. So he has clear cardiovascular disease. He has history of hypertension. He has history of diabetes, hyperlipidemia as well. Cardiovascular disease and heat waves do not mix. There are several climate-related and pollution-related phenomena that affect people with underlying cardiovascular disease and make them even more susceptible to issues like heat waves and things like poor air quality. So this patient was already a high-risk patient for the impacts of climate change, given his underlying history. Another thing to bring attention to is his lack of mobility, his mobility problems. He only has half of his leg is missing. So how is this patient actually getting around? He probably was already predisposed to significant impacts from this heat wave that he's having. So from our perspective, what we're going to do to get ready from this guy is immediately we need to have cooling measures ready. We need to make sure that he's breathing okay, and we may need to protect his airway with intubation and putting him on a ventilator right away when he comes in. He's hypotensive, which means that for some reason, he might be severely dehydrated. So we'll need to resuscitate him with fluids as well. So he's a very sick patient. He's one of our sickest patients. And lastly, it looks like he has poor social support. And so we don't really know a full history on this guy quite yet. And he obviously can't give it to us. He's very altered. So, and the daughter per the case is actually in New York. So how do we know what happened to this patient? Why did he end up the way that he did? It's probably not going to be something that we'll be able to elucidate in the emergency room as we take care of this patient. So this patient represents a lot of different things. We know that he was already at risk given his underlying heart issues and cardiovascular disease and respiratory issues, given that he's a smoker. And then it also poses a wake-up call for the hospital that, hey, if this patient came in, there may be other ones like him out there.
Thank you, Dr. Spirioli. Next, we'll hear from Dr. O'Connell.
So this would be a gentleman that undoubtedly after emergency gets him brought back to medical stability, and he would likely end up admitted to the floor. There may be some consultation that'll happen with his rehabilitation team, particularly if he is presented without an appropriate mobility aid. Hopefully, a goal would be to have an interdisciplinary approach to mitigating the outcomes of his heat stroke, and also looks like to be quite poorly controlled diabetes, and then start preparing for the future. Part of the disaster management with individuals is really knowing what the potential risks are in a particular environment. So if in this particular community that there are known to be heat waves, or known to be cyclones, or known to be earthquakes, whatever that particular disaster may be, it's trying to put in place those types of strategies and plan so that if a disaster struck or a climate-related event struck, that there would be an actual plan in place to help mitigate those potential risks. So for an individual like this, we'd be looking at, does he live alone? What type of supports could be put in place that would allow somebody to have a check-in with him in the event that there are climate-related issues or disaster-related issues? Is there somebody available that can help with particular day routines, such as monitoring of his blood sugars? What types of mobility aids does he have? What types of equipment does he have? How is he able to access those? And is his apartment or his living arrangement actually physically accessible? If there were cooling centers, was he unable to know about them, or was he unable to get to them? It says he lives on a top floor of an apartment and he's an below knee amputation. So is there an elevator? Does he have a prosthesis that fits? If not, what medications is he using? Does he have access to these? His social services need to be involved. Ideally, and we didn't do this years ago. I mean, as we're becoming much more cognizant of just how real these sudden weather events are, and the propensity to disasters. I mean, here in Canada, we're seeing the fires, for instance, being just catastrophic. Now we've had the horrible flooding out in British Columbia. I think with our vulnerable patients, we need to make sure that they have a backup plan, that they have their emergency kit that comes with them and can be used in an instant. It's not going to be an easy task, but I think it's something that we as a specialty and as a health profession, we need to work towards and have that plan with every one of our patients.
Thank you, Dr. O'Connell. And now we'll hear from Dr. Gebauer.
So I'm zooming into his medication-related problems when thinking about what his climate risks are. And he's on multiple medications that actually make him more sensitive to the extreme heat. So first, he is taking an antipsychotic medication, Seroquel. And as I mentioned before, they do carry a warning that they impair core body temperature regulation and predispose patients to hyperthermia. And his blood pressure medications also have this effect to a lesser extent. Then on top of that, he's on a diuretic, hydrochlorothiazide, and diuretics also make people more sensitive to dehydration and electrolyte disturbances and have been associated with heat stroke. And so for these reasons, I think he should be triaged in any situation as a high-risk patient, similar to like a more elderly person. Another sort of medication and climate related risk he has is that he is on the top floor apartment in a place that's, has hot summers and heat waves. And as it has been mentioned, he may not have a lot of social resources. And so, and he's on insulin, which has very particular storage requirements. So that's another medication-related risk he has. When we see the blood glucose of 423, it makes me wonder if his insulin was even working at all, actually, unfortunately.
Thank you. So for our next question, it's more on the preventative side. So in discharge planning for this particular patient and for alerting other individuals in the community, what resources or considerations, I know we've touched on a couple, would you provide to the patient before leaving the hospital? And what tools or other resources can providers use to prepare their patients for heat emergencies, such as what happened in the Pacific Northwest this past summer? And we'll start with Dr. Spirioli.
Sure. So I can tell you that this patient is not leaving the hospital anytime soon. And I see my colleagues nodding in agreement there. So this gentleman, as we pointed out earlier, he's quite sick. So he'll be staying in the hospital. In terms of what I like to give my patients, it's actually two different resources. So yes, as you alluded to, prevention definitely is key. And what's very possible with this patient is he may not have even known exactly what his risk was. And so communicating that risk to these vulnerable patients is extremely critical. And healthcare providers and clinicians are in the perfect position to really do that for their patients. Two resources that I've learned about as I work with the federal government this year that I'm going to put in the chat that I like to share with my patients who come in with climate-related illnesses. One of them is the EPA Air Now app, which is a really easy app to use. The patients can just put their zip code in wherever they are, and it will tell them their air quality in their zip code at that moment. And at the same time, it will also tell them what risk that means. So if they're in a moderate zone or a moderate warning air quality zone, it'll tell them, hey, patients who are sensitive, if you are elderly or if your babies should not be out during this time, it'll kind of give some general guidance to the public. So I always tell my patients anytime I can about that particular app who I deem really to anybody, but definitely to the patients who are vulnerable, who have underlying cardiovascular disease and respiratory disease and are younger. Another app is the heat safety app, heat safety tool that was created by the NIOSH. This is another federal tool to use. Will tell patients their heat index in their community and how to adequately prepare. So these are two federally backed and federally supported apps that that the whole public can really use. So prevention is knowledge at the end of the day. I think providers in general need to have a knowledge on which patients are at risk and how, and patients themselves need to know how to identify when something is going to affect them or not. And I actually looked into this a few years ago, and some heat wave events are actually one of the most underreported and underpublicized events of all climate phenomena. We're constantly hearing about hurricanes and when they're coming and when they're tracking, and the media kind of goes crazy on hurricanes and everybody runs out and buys a bunch of toilet paper and mouthwash and whatever it is, but not done for heat waves, which actually tend to have higher mortality than hurricanes. So these are two really important apps that I like to use, that I share with my patients pretty often.
Great, thank you. Dr. Gabauer, is there a centralized place where people, such as this patient, would be able to learn about their specific medication risks in a heat wave, for example?
Oh, that's a great question. I believe that the FEMA has some resources on this. I think that's maybe the first place I would direct people.
Mhm.
And then I think just their local pharmacist, I think, is also a good resources for people to learn about just their medications and just storage in general. I think is a good place to get.
Thank you. And Dr. Potter, are there any other resources that you would suggest to your patients?
I also suggest the same that Dr. Ciroli mentioned. They're very good, but people need to understand climate variability. So I think what's happening is people are caught off guard. Folks in California and on the West Coast understand wildfires for the most part, that they're part of your history, part of your story, but we don't get those in Minnesota. So this summer, when our air quality was 5 times what the World Health Organization recommends is safe, our people did not know. They didn't understand. Our skies were yellow and orange, and our skies are usually blue. That's what Minnesota means, the land of sky blue waters. So we weren't prepared for disasters. Even people who are well educated and understood, well informed and understand climate change, we weren't prepared for disasters. Similarly, I think my colleagues, and you can speak to that, those of you from Canada, I think climate change kind of caught you off guard. You knew it was real, but I think for a lot of my colleagues in Canada, it was sort of assumption that you had it pretty good. The temperatures weren't going to be a real issue. The water wasn't going to be a real issue. And nobody could have predicted the drastic heat domes in Western Canada. So it's preparing all of our citizens for a very, very strange climate variability, and that there's some nuance to it. It's not just how do you stay cool? Do you have air conditioning? It has to do with your age. Your age can predispose you to more problems. If you're an elder, you're not sweating as much. Children certainly can't complain, and they're more sensitive and aren't thermoregulating as well. If the humidity is high, that compounds the problem. So a heat episode in Arizona is very different than a heat episode in our high humid days in Minnesota. So it's helping people understand these subtle risks and that it's more than just air quality. There's an understanding of what does it do to your lungs. If you have an underlying inflammatory disease or cardiovascular disease, what's actually happening to you? That's what helps people understand is how is this working, and what are the real threats for you?
Thank you, Dr. Potter. Dr. O'Connell, are there any particular resources for those living with disabilities to learn about their climate vulnerabilities?
Yeah, I see Helen Boyd just posted the Air Quality Health Index in Canada, one of the links that you can use. It's difficult to every region kind of has their own sort of resources within their own governments and health systems in terms of tools for assessing their own disaster risk, including those of climate. I think like our approach is really trying to, get the healthcare professionals to be more aware and recognizing that this is actually a very real aspect that needs to be part of all of our assessments with our patients. And as part of our follow-ups with our patients in terms of how is the patient going to recognize and how will they be prepared to respond in response to what they might be at risk for, depending on where they live. None of this was part of our medical training for the most part decades ago. It doesn't have a high prominence yet, even in some of our national meetings. It's still, I'd suggest it's even still considered by some to be a little bit fringe, just starting to intrude a little bit onto the mainstream. And I think, as a health leader, that is one of the areas that's really important, is that we work to advocate with our hospitals, with our health authorities, with our national and regional governments to start making this an integrated part of our health plan. Most disaster planning, I think, well, here in Canada has been about the plane crash. A big plane crashes in downtown, and what are we going to do? Not about all of these other much more realistic things that we're probably going to be exposed to. So just kind of coming at it from that level, I think everybody else has really mentioned already all the resources that you would do for this particular individual. One kind of unique thing that some regions have are kind of, it's called different things in different places, but it's the friendly visitor or the check-in type of system, buddy system, where persons with a disability are partnered up with either a community organization or a group that will check in on them in the event of a particular emergency or threat. In Japan, they have a really well organized system for persons who use wheelchairs as their main means of mobility. They're so earthquake prone that as soon as there's one of those early warning signs and then there's an event, they immediately are getting in touch with their entire registry of those patients to see, are you okay? Do you need transport, et cetera, in terms of arranging for evacuation and resources. So maybe we need to start looking at something like that on a community-based level for our persons who are the most vulnerable.
Thank you. All right, so climate change can sometimes be a little tricky to bring up with patients and their families. This is open to everyone on the panel. What are some strategies that you use to broach the topic, given people's unique backgrounds and perspectives?
I can try to tackle that one. So in the emergency room, those kinds of conversations are usually challenging because typically the patient is coming in very sick, and there's a rapid turnover in terms of how long they're actually in the department, how long the doctors and nurses can really interact with this patient in the emergency room. Normally, when the conversation comes up, it's usually the patient that will actually bring it up to me in some way. And then I'll sort of use that as an avenue to go and talk about climate and health impacts. So for instance, I had a case just a few weeks ago when the wildfires were happening in Southern California. And this patient had been to the ER 3 times in the last 24 hours with an asthma exacerbation. She had underlying asthma. She was a 36-year-old female, otherwise healthy. And I was the third provider that she has seen in the last 24 hours because her asthma was so bad. She kept going home and the wildfire was obviously still going on. And so she just kept coming back to our emergency room. And she herself was like, do you think my asthma is bad because of the wildfire? And I was like, yes, actually, I do think it's that. And then we had a conversation about particulate matter and what her risk is and these kinds of things. So sometimes you have to sort of use the reason why the patient is there or any sort of underlying comorbidity that they may have, to bring their awareness to start thinking about, hey, you might actually be at risk for these changes that are happening in the climate. I tend to avoid actually using the word climate. I usually use environment. It seems to be a little bit more benign, a little bit less politically charged, because you kind of want to try to be unbiased in these kinds of conversations, at least that what I have experienced. But usually that'll be my approach, is if the patient will ask me directly about something, or there's an avenue to kind of dive in and paint the picture of why they themselves are at risk for these particular phenomena.
Thanks. And Dr. Potter, I seen you unmuted.
Yeah, I would really encourage people to connect with their public health nurses and community nurses, home care nurses, who can get into the settings where people live and work and really evaluate their risk and be talking about preparedness and climate issues. I think oftentimes once have a relationship with a patient, the relationship can drive openings. So you can say, oh, I understand you enjoy fishing. Are you seeing changes with the types of fish you're able to catch, and the number of days that you're able to be out on the lake? Are you seeing any changes? And that opens up conversation. And once they start to say, oh yeah, I'm seeing changes, or there's weather change, climate changes, things are different. You can begin to talk about, okay, let's talk about how we're going to protect you. This is real. We're going to be having more events. We have not brought up mental health and well-being changes related to climate change. And that has to be on all of our radar. The most recent CDC report on youth and mental health changes is quite disturbing and concerning. And we're certainly seeing a rise of eco-anxiety and eco-despair in young people. So I think we need to be evaluating people for depression and for hopelessness. All the good treatment plans and pharmaceuticals in the world are not going to make a difference if people are in such despair that they aren't able to follow their plans. So we all need to be asking about that.
Great, thank you. For our next question, we had touched on this at the very beginning of the case. Since this case is set in a heat environment, what protocols are in place for the health system to accommodate for the large influx in cases, and what does the process look like for cooling centers? How do patients learn about that? How does the emergency department quickly alert people that a heat wave is happening? And again, this is open to anybody on the panel.
Just speaking, not necessarily coming from Canada, but from a first world country, it's important to know what the means of communication is by the majority of people who live in the region that you're trying to contact. In one territory, an emergency alert might be best done through radio, or it might be best done through a cell phone. In other areas, it might be best done through an app such as WhatsApp, which has through various social circles, for instance. When dealing with certain populations, like for instance, if you're talking about a particular disability group, either a mental health group or multiple sclerosis or spinal cord injury, there's often very strong social networks within those groups themselves that you can actually get on board to be part of your education and dissemination group. So I don't think there's a one size fits all. I think it is really dependent upon what type and mode of communication is accessible to the people that you're trying to reach.
Great, thank you. And we also have in the chat, I think it's a direct message. We had some folks interested in learning more about RX for climate and sustain our abilities. So Dr. Galver and Dr. O'Connell, we'd love to hear from you on that.
Oh, sure, I'll start. I also wanted to add about the health system. An important lesson we learned here in West Virginia a few years ago with the floods was that it's important to make sure that state laws are in place to allow emergency protocols to function. Because what happened here was that at the emergency clinics, we had pharmacists who wanted to come from out of state to help. And they had to go through a long, licensing process before they were allowed to. And the same with mobile pharmacies trying to come in and getting really delayed because we didn't have a plan in place. And my colleagues have been working on advocating to change that. And I know that we're not the only state that is in this situation that needs to advocate for more disaster preparedness plans. Just wanted to, I thought it was an interesting thing. The RX for Climate, I'm really glad that people are asking about it. So it's a very new fledgling website that I've started with some colleagues around the world who are interested in what is pharmacy doing about climate change. So I think we've really connected on trying to advocate for more introduction of this topic into pharmacy curricula. And we're trying to build a wider network of pharmacists who are interested in, really increasing pharmacists' ability to help with these problems. And we are rxforclimate.org, and if you go, there's a link to please sign up, and we'll be in touch with you.
Thank you. And Dr. O'Connell, would you be able to tell us about Sustain Our Abilities?
Sure. So Sustain Our Abilities is actually founded by Dr. Marka Lisipski, who I mentioned at the beginning of the session, really out of her very growing concern about the climate and its impact on the world in general, but very particularly around persons who are most vulnerable, those with disabilities. So it's a network of clinicians and volunteers with some connection to the rehabilitation world. So this is persons with lived experience who they themselves have some form of disability, with physicians and nurses, therapists, advocates, community workers. And the main thrust of what we are doing is trying to improve and disseminate education about the implications of climate change, but also provide in a climate-friendly forum educational opportunities for persons who are living with disability. So it's kind of trying to use a climate-friendly and green approach to providing education and training. So avoiding having to have these in-person meetings and all the flights and paper that's associated with that. And at the same time, having a very strong focus on educating and advocacy around climate and climate change. And we have members from countries all over the world, and we have been regularly hosting and posting a number of different asynchronous and synchronous educational activities, YouTube videos, training videos across a wide domain of topics in multiple languages as well. So I'll try and post one of the YouTube channels, and also it'll be a link to, I think, the website as well. So I'll send that in here. And again, Dr. Marka Lee is sort of the founder and the leader in that group as well.
Great, thank you, Dr. O'Connell. Thanks for everyone who submitted questions in the chat. I know we have a couple minutes left. Just wanted to open it up in case anybody had some new ones pop up. All right. Well, I wanted to share a couple more opportunities like this that are happening through the consortium. I'm going to share my screen real quick. All right, so the Climate and Health Responders course for health professionals is open to faculty and students. It's launching in February. And through the course, there are several breakout sessions geared towards students that use case-based sessions just like this to explore interprofessional teamwork for climate emergencies. So if you're interested, I'll paste the link in the chat. Please feel free to explore the website and sign up. We also have another opportunity. There we go. There we go. The Climate Resources for Health Education program that we're launching through the consortium in collaboration with Harvard, MGH, and Brigham Women's Hospital, as well as UCSF. And so this is an opportunity, as we've discussed today, to create content to educate health professionals across the board on the impact of climate on health. You can sign up to be a slide or case writer or an expert reviewer. Feel free to scan the QR code on your screen, or again, we'll paste the link in the chat. With that, I just noticed a chat pop up. I want to make sure that we get everyone's question. Yes. And with that, thank you to our panelists for joining us today. I learned a lot. I hope you all did too. Thanks for sharing your expertise. And the recording for the session will be going up tomorrow with all of the case materials, as well as all the bios for our panelists, so you can learn more. Thank you for joining us. Thank you, Haley, for pasting the links in the chat.
Thank you so much, everyone.
Thank you.
Bye-bye.
Thank you.
Thank you very much.